Every year, millions of people over 65 agree to surgeries they were told would change their lives, and for some of them, it does. But for a significant number, what changes is not what they expected. The pain continues. The recovery takes longer than anyone described. New complications arrive. And sitting in a follow-up appointment 6 months later, they say something I have heard more times than I can count. "Doctor, I wish someone had told me the odds before I said yes." That is what today is about. Not telling you to avoid surgery. Surgery saves lives, and I have seen it do exactly that. But there are 6 specific surgeries where the data, across thousands of patients and multiple decades of outcomes research, consistently shows that older adults experience results that fall significantly short of what they were expecting when they agreed. 6 surgeries where asking harder questions before saying yes changes outcomes dramatically. My name is Dr. David Mercer. I have spent 28 years studying aging patterns in over 9,000 patients between the ages of 65 and 95. Some of what I am about to share will be uncomfortable because it involves situations where the medical system, operating with entirely good intentions, offers a surgical solution to a problem that the data consistently suggests may respond equally well or better to a non-surgical approach. The surgeon recommending the procedure is not wrong to offer it, but the patient agreeing to it without knowing the full picture of what outcomes look like for someone their age with their condition is making a decision with incomplete information, and the outcomes literature shows that consistently produces results that fall short of what was expected. Informed patients get better outcomes. That is not an opinion. It is a consistent finding across decades of research. Subscribe before we continue. What comes next belongs in every pre-surgical conversation that is currently not happening. Surgery number 1. Spinal fusion for chronic lower back pain. This is the surgery that comes up most consistently when I review outcomes data for older adults, and the one that I spend the most time in pre-surgical conversations addressing carefully. Spinal fusion is a legitimate and sometimes necessary procedure. When there is genuine instability, when there is neurological compromise, when specific structural conditions meet specific surgical criteria, spinal fusion has a clear role. The problem is that it is also performed extensively for situations where those criteria are not clearly met, specifically for chronic degenerative lower back pain without significant neurological involvement in patients over 65. Here's what the outcomes data shows over and over. Studies following large populations of patients who had spinal fusion for degenerative back conditions show that between 40 and 50% report persistent or worsening pain at 2 years after the surgery. The surgery relieves pain for roughly half and fails to relieve it for roughly half. Meanwhile, the same patient populations followed through physical therapy, anti-inflammatory management, and targeted rehabilitation show improvement rates that are comparable and sometimes exceed surgical outcomes over the same time frame without the surgical risks. For patients over 65, there are additional factors that shift the calculus further. General anesthesia carries a higher risk of post-operative cognitive decline in older adults. The spine of a 70-year-old heals differently from the spine of a 45-year-old. Adjacent segment disease, where the segments above and below a fusion begin to degenerate because the fused segment no longer absorbs movement, is more common and more problematic in older adults because the surrounding spine is already showing age-related change. Failed back surgery syndrome, a clinical term for persistent pain following spinal surgery, is more prevalent in older patients and harder to treat when it occurs. A man named Richard came to see me at 68 after having 2 spinal fusions in 3 years. The first surgery had been for significant disc herniation with nerve involvement, and the surgical indication had been reasonable. The problem was the second surgery, performed when his pain returned, and the third he was now being encouraged to consider. Each fusion had been followed by genuine improvement that then faded as the adjacent segments of the spine began to show the degeneration that had been predicted but not communicated to him clearly before he agreed to the first procedure. When I reviewed his imaging with him carefully and spent real time explaining what he was seeing, what I showed him was not a spine that was failing the surgery. What I showed him was a spine showing the natural progression of age-related degenerative change that no number of additional fusions would reverse or stop, because fusion addresses a specific mechanical configuration at a specific level, not the underlying biological process that drives degeneration throughout the spine. He had not understood that distinction before his second surgery. He had believed, reasonably and in good faith, that the surgery would address the problem rather than one expression of it. We started him on a structured physical therapy and pain management protocol that had been entirely bypassed in favor of surgical options at each decision point. 8 months later, Richard was managing his pain significantly better than he had at any point after either surgery. He told me, quietly, that he wished someone had told him to try this path first. Before I walk you through the remaining 5 surgeries, I want to say this clearly. If you want to go beyond these 6 surgeries and learn about the 17 health concerns that matter most after 60E, from strength and mobility to heart health, brain health, nutrition, and sleep, I have put everything into one straightforward ebook with practical steps you can actually use. The link is in the description below. Now let us get into it. Surgery number 2. Knee replacement for mild to moderate osteoarthritis. Total knee replacement is one of the most successful elective surgeries in modern medicine for the right patient at the right stage of disease. I want to be precise about that because the surgery itself is not the problem. The problem is who receives it and when. Research tracking outcomes across thousands of knee replacements has consistently found that patients with severe osteoarthritis at the time of surgery have the best outcomes. Patients with mild to moderate disease, who are often offered surgery because their pain is affecting quality of life and imaging shows changes, have significantly lower rates of satisfaction and more frequently report that the knee after surgery is not substantially better than the knee before surgery. The mechanism here matters. Knee replacement replaces the joint surface. It does not address the muscular weakness, gait changes, movement patterns, and central nervous system adaptations that chronic knee pain creates over years. A patient who has been moving compensatorily for 3 years because of knee pain will continue to move that way after the mechanical joint is replaced, which means the pain often persists through different mechanisms. Physical therapy before surgery, specifically designed to maximize muscle strength and correct movement patterns, consistently improves outcomes when surgery does occur. And in patients with mild to moderate disease, it frequently reduces pain enough to defer or avoid surgery entirely. I worked with a woman named Margaret, 71, who had been scheduled for a knee replacement for 8 months of knee pain with moderate changes on imaging. She wanted a second opinion before proceeding. When I reviewed her evaluation, there had been no structured physical therapy program before the surgical decision, no trial of targeted weight-bearing modification, and no assessment of her hip and ankle musculature, which are frequently the primary drivers of knee pain in patients who assume the problem is the knee itself. We spent 12 weeks on a structured program addressing every contributing factor. Her pain reduced by approximately 60%. She has deferred the surgery indefinitely and sees it now as something that remains available if circumstances change, not as something she is avoiding. Surgery number 3. Coronary artery bypass grafting when medical management is appropriate. Cardiac bypass surgery is an extraordinary procedure and it saves lives in specific circumstances, specifically in patients with left main coronary artery disease, in patients with multivessel disease in the context of reduced heart function, and in patients with angina that genuinely does not respond to maximum medical therapy. What the data shows is that for patients with stable coronary artery disease, meaning blockages that are causing symptoms but not causing ongoing damage, optimal medical management, which includes medication, lifestyle modification, and structured cardiac rehabilitation, produces outcomes that are equivalent to surgical revascularization across all major endpoints, including mortality and heart attack rates. For patients over 65, there is an additional consideration that deserves specific attention. Post-operative cognitive decline following cardiac surgery is well documented. The cardiopulmonary bypass machine, which takes over heart and lung function during the surgery, is associated with measurable cognitive changes in a significant percentage of older patients. This has been studied extensively, and the effect is real, particularly in patients who already have mild cognitive changes before the surgery. The cognitive decline can be temporary, or it can persist. Families who watched a relative seem cognitively different after cardiac surgery are not imagining it. The effect has a name, a mechanism, and an outcomes literature. A man named Leonard, 73, was referred to me after recovering from bypass surgery for stable angina that had not received an adequate trial of medical management before the surgical decision was made. His family brought him to see me specifically because they felt he seemed different after the surgery. His memory was less sharp. His processing was slower. He lost his train of thought in the middle of sentences in ways that had not happened before. His cardiologist told them the change was unrelated to the surgery, that this was simply aging. When I reviewed the timeline with the family carefully and compared Leonard's cognitive function before and after the surgery using the assessments in his records, the profile of the change was consistent with documented post-operative cognitive decline rather than with the natural trajectory of age-related change. The pattern, the timing, and the specific domains affected all pointed in the same direction. He had been offered surgery for a condition that had an equivalent non-surgical option. He had received it before alternatives were tried seriously. The surgery achieved its cardiac objective. The cost was cognitive function he has not fully recovered. He is improving, slowly, but the improvement is measured from a baseline that is lower than where he started and lower than where he might have remained had the available alternatives been given genuine consideration first. Surgery number 4, carotid endarterectomy for asymptomatic carotid stenosis. This one is less well known to patients and more important than most of them realize. Carotid endarterectomy is a surgery that opens a narrowed carotid artery, one of the major arteries supplying blood to the brain. When performed for patients who have had a transient ischemic attack or stroke attributable to carotid disease, the surgery has clear evidence supporting it. The regret data clusters in a different situation, specifically in patients who have carotid stenosis discovered incidentally on imaging, who have no symptoms whatsoever attributable to that stenosis, and who are offered surgery prophylactically. Major clinical trials examining this question have shown that in asymptomatic patients, optimal medical management, meaning antiplatelet therapy, statin treatment, blood pressure control, and lifestyle management, produces stroke rates in the 10-year range that are comparable to or better than surgery in many patient subgroups. The surgery itself carries a procedural risk of stroke and death that in older patients with other health conditions can offset the theoretical protective benefit. Put plainly, in some patients, the surgery intended to prevent a stroke can cause one. A woman named Dorothy, 77, came to see me with a surgical recommendation for carotid endarterectomy based on a 70% stenosis found on imaging done for an unrelated reason. She had never had symptoms, no episodes of weakness, no visual changes, no speech difficulty. When I reviewed her overall cardiovascular profile with her, she was already on appropriate medical management for her blood pressure and cholesterol. We discussed the trial data in detail, and she decided, with her vascular surgeon's awareness and agreement, to pursue optimized medical management rather than surgery. 2 years later, she has remained asymptomatic, and her most recent imaging shows stable stenosis. Surgery number 5, radical prostatectomy for low-risk, low-grade prostate cancer. This is perhaps the most data-rich example on this list because prostate cancer surgery in older men has been studied extensively, and the findings are consistent and striking. For men over 65 diagnosed with low-risk prostate cancer, specifically Gleason grade group 1, which is the most common finding at diagnosis, randomized controlled trials and large observational studies show that active surveillance, meaning careful monitoring without immediate treatment, produces 10-year and even 15-year survival rates that are equivalent to immediate surgical removal. The difference is not in survival. The difference is in what the patient experiences. Radical prostatectomy carries significant rates of urinary incontinence and erectile dysfunction that are permanent or persistent in a meaningful percentage of men. These side effects profoundly affect quality of life. When the survival benefit of the surgery is essentially zero compared to watchful waiting in low-risk disease, those quality of life costs represent outcomes that a substantial number of men, when reviewing the data after the fact, identify as a trade they did not understand they were making. I had a patient named Gerald, 68, who came to me for a second opinion after being told he needed immediate surgery for a newly diagnosed prostate cancer. His Gleason score placed him in the lowest risk category. I spent considerable time reviewing the current outcomes data with him. He was surprised to learn that active surveillance with regular monitoring was not a compromise or a delay. It was a legitimate primary management strategy for his specific diagnosis with equivalent survival data. He chose surveillance. He has been monitored carefully for 3 years. He has maintained his quality of life fully. He knows the surgery remains available if his disease changes. It has not. Surgery number 6, elective cholecystectomy for asymptomatic gallstones. Gallstones are extraordinarily common after 65. Studies suggest that 30 to 40% of adults over 70 have gallstones detectable on imaging. When gallstones cause symptoms, specifically biliary colic, the characteristic right upper quadrant pain after fatty meals, or when they cause complications like cholecystitis, cholangitis, or pancreatitis, surgery to remove the gallbladder is clearly indicated and generally well supported. The problem arises with incidental gallstones discovered on imaging done for another reason entirely. In younger patients, there is reasonable argument for preventive removal because the lifetime risk of developing symptoms is meaningful. In patients over 65, the math changes. The majority of people with asymptomatic gallstones at 65 or 70 will never develop symptoms from them. The surgical risk of cholecystectomy, while generally low in younger patients, increases meaningfully with age and with the presence of other health conditions that are more common in older adults. Complications of anesthesia, wound healing challenges, bile duct injuries, and postoperative infections all become more frequent considerations. A woman named Frances, 74, was told following an abdominal ultrasound done for an unrelated complaint that she had several gallstones and that removal should be considered to prevent future complications. She came to me for a discussion of the recommendation. She had never had a single symptom. Her overall health profile included cardiovascular disease that would increase her surgical risk meaningfully. When we reviewed the actual probability of her asymptomatic stones causing a problem requiring emergency intervention versus the procedural risk of elective surgery in her specific health context, she elected to continue without surgery and manage any future symptoms when and if they occurred. She remains asymptomatic 2 years later. 6 surgeries. Spinal fusion for chronic back pain without clear surgical criteria. Knee replacement before conservative management has been genuinely exhausted. Cardiac bypass for stable coronary disease in patients where medications have not been given adequate trial. Carotid surgery for asymptomatic narrowing discovered incidentally on imaging without symptoms ever having occurred. Radical prostatectomy for low-risk prostate cancer where active surveillance produces equivalent survival outcomes across every major study that has followed patients long enough to know. Elective gallbladder removal for stones found accidentally in patients who have never had a symptom and whose overall health profile elevates their surgical risk beyond what the preventive benefit justifies. The message I want you to take from this video is specific and actionable. When surgery is recommended, ask 2 questions before agreeing and before scheduling anything. First, what does the outcomes data show for patients my age with my overall health status and at my level of disease severity? Not what surgery can achieve under ideal circumstances, not the best case result. What the data shows it achieves on average for people who share my profile. Second, what is the strongest non-surgical alternative available? Has it been given a genuine and complete trial? And what does the data say about where that path leads compared to surgery? Those 2 questions are not obstruction. They are not resistance. They are the questions that separate patients who make fully informed decisions from patients who make partially informed ones. Every good surgeon I know welcomes those questions. They are the questions that protect both of you. You have a right to that conversation. You have a right to the time it takes to have it properly. And if the recommendation you receive does not hold up to those 2 questions clearly and specifically, a second opinion is not disloyalty to your physician. It is what informed patients do. Richard got a second opinion. Margaret got a second opinion. Gerald sought additional information before proceeding. Their outcomes are different because of it.